Is the future likely to be focal prostate cancer management in a couple of years? Disruptive technology. What does that mean? Well, if you have a technology that has been a standard, and you come along and you begin to see beyond what you could see before, inventive technologies that give you insights that you couldn't get. And all of a sudden, the leader, the prime point of progress, loses its energy. And this is from the Harvard Press, when new technologies cause great firms to fail. You kind of look at email in the post office as a good example. Options for men who we think have low volume, low grade tumor. Well, they can have radical treatments, they probably can be cured. It doesn't always play out that way. So there is an incontinence rate, impotence rate, and if you're talking about radiation, there's toxicity of the organ systems around prostate. If you look at active surveillance, which means if you have low-grade, low-stage disease, some of those tumors will progress, and patients will have disease that's more aggressive and a bigger problem to deal with. People are concerned about having a cancer that nobody's doing anything about, and then there's the cost of surveillance. So focal therapy is sliding right into the middle of this. So how do we select these patients? Well, right now we're dealing with the low-risk disease. The PSA is below 10. The low-volume cancers in the prostate, T1C, you can't find the lesion. You're tripped to it because the PSA is up. T2A, you can find the lesion, but it's hard to find. T2B, you can find a little more easily, but it's in one portion of the prostate. It's not throughout. The Gleason score, well, we could spend a long time talking about Gleason score, but it's the way the pathologist looks at the tumor and says this is either a slow grower or it's an aggressive tumor. Now this is a little more graphic. This is bilateral disease, proven, and this is unilateral disease. But what you find is as you diagnose patients who have a higher percentage of bilateral disease, the numbers of patients who have only unilateral disease diminishes. And if we look at the Gleason grading system, if we have a Gleason grade below 7, we see a lot of unilateral disease, and if we have a Gleason grade above 7, we see less, significantly less. Now these are all peer-reviewed articles. About 20% of those patients have disease that is amenable to local or focal therapy. Well, if you consider that it's really 187,000 new cases of prostate cancer were diagnosed in 2008. But the bottom line is, we know that there is a group of patients that can be treated very successfully with less aggressive treatment. Essentially, 1 in 5 men have one-sided prostate cancer. That means they have low stage and low grade. So the concept of unilaterality is pretty much where we are today. Why do we do that? Because gentlemen who have a diagnosis of prostate cancer want to have quality of life. They don't want to wear diapers. They don't want to be impotent. They want to be normal. And this is the key to that normality. So how do we do it? The method for freezing. We believe we can identify lesions in the prostate of certain size. We know we can use a saturation biopsy. We know that imaging modalities are improving. Cryoablation. We treat it and then we do an ultrasound after a period of healing. This is what it looks like. Patient selection. We'd like to see unifocal, but we'll settle for unilateral. We're willing to say that if we use Doppler, and I'll show you how that works here in just a minute, or saturation biopsy, we can be pretty sure of what we're dealing with. So the person that would go for this would be very interested in maintaining quality of life issues, and he would be willing to be involved in a more involved and demanding follow-up program. Here we have a gentleman that had a low-grade, low-stage lesion. and he was entered into an active surveillance program. In 2007, the PSA was up, and there's a lot more here. When it was biopsied this time, it was a Gleason grade 7. It involved 90% of the core, and the PSA, as I just showed you, was higher. When we started, it was tumor in 10% of the core, and it was a Gleason 6. Here is this tumor, and what we're doing is we're treating it by bringing the ice down and essentially snuffing out that group of cells, which are the aggressive cells that made up that cancer. This is a series of people who are using this approach: Dr. Lambert, Dr. Bond, Dr. Onik. This is the disease-free state, and the numbers here are really pretty high. This is Dr. Bond's work, and it tends to show the same thing, but in this case, we're talking about potency preservation. Here is focal therapy. 89% of these patients are not erectile dysfunctional, they're functional. Focal subtotal cryo is a minimally invasive procedure. There's a high rate of potency in urinary continence preservation. It fills the void between active surveillance and aggressive therapy. The Society of Interventional Radiology met in March of this year. Their position was that focal cryoablation represents a middle ground between watchful waiting and aggressive radical treatments. The disease recurrence rate is low, very acceptably low. Dr. Onik is the individual who reported this study. It is 120 men during a 12-year follow-up period, 72 of them being in the aggressive D'Amico classification. At a mean of almost 4 years, 93% of those patients had no evidence of disease. Focal or subtotal treatment of prostate cancer, according to some people, is here. We're working at trying to make it a concept that's agreed upon by the majority of professionals, but I don't think it's very far away.